Hello, everybody. I hope you're doing well under the current circumstances. A few days ago, on April 1st, I put together a presentation that focused on US-based surveillance of COVID-19. And as promised, I have put together a second presentation, this one focusing on the topic of flattening the curve. My disclaimers, just as last time, I am an epidemiologist with 25 years experience. However, I am not an infectious disease epidemiologist nor an outbreak epidemiologist. Also, I've assembled this on my own. Therefore, my opinions that I present are not necessarily shared by my current employer. Again, we'll be talking about flattening the curve. I hope you enjoy my little clip art. My 9-year-old daughter gave it her thumbs up. And what my goal here is to give you a general background of what we know in terms of what the COVID-19 impact is going to be on the United States. And once again, just as in my last presentation, I'll be focusing on high-level information that has been prepared by experts in both government and academia. This time specifically, I will largely be talking about some of the research that was touched upon on the March 31st White House press briefing. I'm hoping that this presentation will provide you with a better understanding of two questions that I am getting asked all the time, which are basically, how bad will this be and how long will it last? Before I do that, I want to talk briefly about pandemic preparedness. I am not going to go down a wormhole of talking about US preparedness, but I will say that globally we were not prepared. There are dozens of peer-reviewed articles with similar messaging to the two I'm focusing on here, and these two were both published in prominent medical journals. I've reviewed quite a few of these, and I don't recall any suggestions that stated that the world was well prepared for this. Well, anyhow, the first one here was put together about 6 years ago, and it was authored by Harvey Feinberg, who's a renowned researcher in the fields of health policy and medical decision making. He was once the dean of the Harvard School of Public Health, as well as the president of what is now the National Academy of Medicine. And back 6 years ago, he was warning about insufficient resources to deal with a pandemic. This second paper was put together by the Lancet Infectious Disease Commission, and this caught my eye because it's very recent, January of this year, right before, or essentially right as everything with COVID-19 was starting. And they are talking about being prepared and how difficult that is given a constantly changing world. And they also are talking about that right now we have an underprepared world. So again, these are just two papers, but there are dozens out there with similar messaging. Conceptual explanation of flattening the curve. We have all seen this graph or something very similar to this graph, and we're going to see quite a few of them during this presentation. Therefore, I want to give it a little bit more explanation than you may have received before. For starters, the x-axis, the days after initial outbreak, days, that's pretty constant. That is going to be essentially the same in every graph we see. Sometimes it might be presented as weeks or even months, but that's just the hash marks on the x-axis. We're really always talking about days after initial outbreak on this x-axis. The y-axis, what is number of cases here, is a little more complicated. That could be an actual count, which is a daily prevalence, such as what we have here, the number of cases. Other possibilities are number of fatalities, number of hospitalizations, number of ICU admissions, or number of ventilators. or sometimes it is expressed on a per capita basis. This is a daily incidence, it's a rate, and it's expressed as a number per X amount of people. For instance, a number per 100,000 people. It may be a number per 1,000 persons or a number per 10,000 persons, but it's always a rate. In some of these, we see a line representing the capacity of the healthcare system. Now, this is only applicable for things such as hospitalization, ICU admissions, and ventilators. It would not be applicable for fatalities, for instance. It really has to do with healthcare utilization. And when that happens, the y-axis could change. We could then have a y-axis that is represented in excess demand. Again, it could be excess demand represented as a count or as a rate, but it would be as excess demand. So really, when you're looking at these graphs, you really need to look at this y-axis carefully. The x-axis is pretty constant. We need to look at the y-axis pretty carefully to make sure that we are interpreting the graphs correctly. Quick history lesson before we get into what's happening now with COVID-19. And that comes from 102 years ago with the Spanish flu. Some background information is that the Spanish flu infected about 500 million people, which at the time was about 1/3 of the world population. And there were in between 50 and 100 million deaths worldwide. In the United States, there were in between 500 and 675,000 deaths, but the intensity varied widely among US cities. And we've probably all seen a graph like this. This is the best version of the graph I have been able to find. But here we could see two cities, Philadelphia and St. Louis, and that there was a much different impact the Spanish flu had a much different impact in those two cities. Now, at the time, there was no vaccine and there were no antibiotics to treat against secondary infections. Therefore, control was limited to non-pharmaceutical interventions, such as personal hygiene, disinfectant use, limitations on public gatherings, isolation, and quarantine. Sounds very similar to what we are dealing with now with COVID-19, and these NPIs were applied unevenly. This graph, the contrast between Philadelphia and St. Louis, provides a great textbook example. In Philadelphia, as we could see from the graph, they had their first case of the Spanish flu on September 17th. Now, what they didn't put in this graph is that on September 28th, there was this Liberty Loan Parade. That would be right around there if they had put it on the graph. Now, that was a gathering where tens of thousands of people were lined on the street for the parade. And because of that, there was a lot of passing of the infection from one person to another. They put interventions in place a few days later on October 3rd. The response time from the first case to when interventions were put into place was about 16 or 17 days. By contrast, in St. Louis, they had their first case on October 5th. They put interventions in place on October 7th. We had a response time of 2 days. And as you can see from looking at the graph, it's a much different story between the two cities. In Philadelphia, they had, again, here we're looking at rates, and we are looking at deaths. They had a peak death rate of approximately 250 per 100,000 people. And the peak death rate in St. Louis was approximately just over 50 deaths per 100,000 people. So two very different stories, but very similar issues to what we have going on now, 102 years later. So bottom line is we have known for a long time that non-pharmaceutical interventions can work. And by the way, these are just 2 cities. The research on here focuses, depending on the research article you look at, in between about 15 and 25 cities, but these are just 2 extremes. So now I want to quickly talk about some modeling. Specifically, this model is from the Harvard Global Health Institute. It wasn't published in the scientific literature. It was published in Health Affairs blog and New York Times. I sort of assembled the information, but it was all put together again by the Harvard Global Health Institute. Specifically, the key person was a Dr. Ashish Jha, who's the director of that Global Health Institute. And I have, in my opinion, improved some of the illustrations to make some points here. But basically what we're looking at here is 3 epidemic curves. One occurring over the course of 6 months, that would be the blue curve, one over the course of 12 months, which is the orange curve, and one over the course of 18 months, which is the green curve. Their estimate is in the United States, there are currently about 85,000 ICU beds. And again, we always have to look at this axis. We're talking about ICU beds here on this epidemic curve. Now, in reality, there aren't really 85,000 ICU beds because other things other than COVID-19 happen. So they put together some very aggressive assumptions, and even with those very aggressive assumptions, the best case scenario is that in reality, there would be 58,000 ICU beds. So here's the whole concept, is that anything above this red line, anything in these curves above this red line is the excess demand. So you can see in all 3 scenarios, there's an area above the red line, that is the excess demand. So what we need to do is build up the healthcare capacity so that it will be above what the projection is when the epidemic curve gets to the peak. So with social distancing, what I'm calling social distancing 1, we would need to get it to about 150,000 beds, ICU beds available, which again, that is someplace in the neighborhood of 90,000 more than is available on a national basis. If we put together more aggressive social distancing, what I am calling social distancing 2, we come up with approximately a 40,000 ICU bed shortfall. Again, this is based on these projections, this model. Here are some of the methods. I'm not going to get into all the details here, but basically they used data from the American Hospital Association, the US Census, and recently published reports that are focusing on COVID-19 surveillance. They made some assumptions regarding infection rate, length of stay. I mentioned this very aggressive assumption that led to the potentially available ICU beds. And again, on the analysis, 6, 12, and 18-month transmission curves. The one thing I want to point out here is that they did this for 306 hospital referral regions. If you follow these links, there is all sorts of information that would be worth looking at. I suggest you do so if you're interested. There are heat maps representing the specific shortfalls in each of those 306 hospital referral regions within the United States. Okay, now we're moving into the March 31st White House press briefing. This slide is directly from that press briefing. And again, we see this graph, very similar to what I presented a few slides ago. We have daily cases, days since first case, and what they presented in the White House is this, that with no intervention, that we could have seen as much as 2.2 million deaths. Now that came from a study that was published in mid-March by the Imperial College COVID-19 response team. And the other thing they talked about was this 100 to 240,000 deaths with interventions. And the reality is, I am unsure where that came from. There seems to be a lack of transparency about where this range came from. I can make some guesses, and my expectation is that it is a culmination of projections that came from academia and business analytics or consultancy firms. And I'm stating that because some of the governors have been very candid that they are getting projections from many places, and they sort of bring it all together to try to get the best picture of what's going on. So if that is happening on the state level, I am going to assume that it is happening on the federal level. So this is figure 1 from that paper. And right there, you could see that 2.2 million. So basically what that means is, again, the Imperial College, that is in the UK, so the paper actually had more of a focus on Great Britain, but we'll focus on the US components of it. And this 2.2 million basically means that everything under this blue curve, all the deaths that come in under that blue curve, would sum up to be 2.2 million. And you could see that in figure 1B for the United States, they looked at the epidemic curves of each state. And the reason they did that for the United States and not in Great Britain is because Great Britain is a smaller geographical area. Therefore, everything's going to happen relatively quickly there. In the United States, because it is a much larger geographical area, we're essentially going to see different epidemic curves. These aren't labeled. I would suspect this first one would be representative of New York, and then the 49 other states occurring after that. And again, here, notice that this is on a case per 100,000 population. However, notice that this is not scaled. And that's important to point out, because what's really happening, and again, excuse my clip art abilities here, but what's really happening is this: if you have these 50 epidemic curves going on, one per state, and those all kind of fallen under this larger blue curve representing all of the United States. So I just wanted to point that out, because it's really very important to understand that when we're looking at this from a countrywide perspective. In addition to the fatality curve over here, there were some other interesting things in this paper, mainly being that the ICU bed capacity would be exceeded by the second week of April. And if left unmitigated, again, that was if left unmitigated, and if left unmitigated, the ICU demand could be as much as 30 times greater than what is available in the United States. And then they looked at the most effective mitigation strategy, which included case isolation, household quarantine, and social distancing of the elderly. And here in that situation, they found that for both general ward, basic hospital beds, and ICU beds could be exceeded by at least 8-fold. So again, not conceptually that dissimilar to what I showed you from that study out of Harvard. In terms of methods, again, I don't want to get into methods a lot here, but conceptually it is very similar to that other study. They put together a synthetic population using census data. Here they did things a little different. They looked at population density and made inputs regarding class sizes and staff to student ratios in schools, likewise in workplace size distribution. There are a whole bunch of assumptions in this data. I'm not going to go through all of them. I think the key point here, or not a key point, but a point I want to make, is this R naught of being 2.4. That is the basic reproduction number. And basically what that is the expected number of cases directly generated by one case. So all that 2.4 means is that each case of COVID-19 would directly generate 2.4 additional cases. Again, that's without any interventions or mitigations in place. Another slide that they presented in the March 31st White House press briefing is this one. It is being referred to as either the IHME model or the Chris-Murray model. Now this slide, first of all, it is published. It has not yet been peer reviewed, but it is published. And the first thing here, right from the slide from the White House press briefing is, again, this was on March 31st, they were estimated 14 days until a peak in the count of the number of daily deaths. So that's the 14 days from the March 31st to when that hits its apex. This dotted line hits its apex. They were also estimating just over 2,200 COVID deaths per day at the highest number, at the apex. So again, if right at the highest point of this dotted line is 2,214. They're also put in here 95% uncertainty intervals. More typically in epidemiology and in biostatistics, we refer to these as confidence intervals. It's the same thing. The definition, actually it's not my favorite definition, but it's the simplest correct definition, is that there is a 95% confidence that the interval XY covers the true population mean. So what does that mean? If X is the lower confidence interval or the lower bound of the uncertainty interval, we follow this black dotted line and we see this blue shaded area, it's right there. Likewise, Y is at the top. So we could see here that the 95% uncertainty interval ranges from approximately 1.25 thousand to 3.25 thousand. And again, the mean was at 2.2 thousand. Some of the methods regarding this model, I'm not going to get into the details here, just like I'm not on the others, but just a few things is that, again, similar information data went into the model. We talked about some assumptions. I'm not going to get into those. The key point is here. This is a dynamic model. The other models I presented were static. They were made on the data that was available at the time, and that was it. This model is dynamic. What does that mean? That means they had a starting point with available data, but on an ongoing basis, they are bringing in more data, and the projections from this model are changing on an ongoing basis. So this is a good thing. The other thing I want to point out is they did things a little different than many of the models out there. They focused on the death rate. And the reason they did this is they assumed that there would be less underreporting or bias involved in record keeping for COVID-19 deaths. That would not necessarily be true for hospitalizations and certainly not for cases. Cases, we all know, because of the issues with testing, are probably grossly underrepresented. And again, the prior 19 forecasts have largely been based on starting with those that are susceptible to those who are infected to either a recovery state or death, which are known as SIR models. And again, this sort of just points out what I was just stating. They use data from outside of the US because their initial data available within the US was very limited. It only included 46 deaths. It also included 122 and 509 ICU admissions and total hospital admissions. So they brought in data from other countries to help start the model. And again, it's a dynamic model, so as more and more, as the situation matures in the United States, they continuously update this model. So this is figure 4 right out of the paper. And again, here we are actually, there are two axes to look at. The first one is just the count of deaths. And here we're looking at this sort of dotted red line, and we go over to the right-hand axis. And we could see that the daily deaths will be at approximately 2,300 at the peak of the apex. Peak hospitalizations, now we're going to the left-hand axis, and the blue line will be at about 230,000. Peak ICU admissions at about 35,000, and peak ventilators, or the need for ventilators, will be at approximately 20,000 ventilators. Here is another figure straight out of the paper. And here we are looking at excess demand. And basically what we're seeing here, again, but at a peak at approximately the second week of April, we will see that the excess demand will be in excess of 64,000 hospital beds, and that's represented by this blue line in the blue shaded area. And again, we have that uncertainty interval, which is approximately 8,000 to 251,000. And there'll be an excess demand of a little over 17,000 ICU beds. And again, here you see the green line, and you could look at the green shaded area for the uncertainty interval. So anyhow, this 64,000 beds, that represents about 7% of all hospital beds nationally. So basically it means we will need, on a national basis, about 7% more hospital beds than we have available. For ICU beds, it's a little bit grimmer. For ICU beds, we'll need about 25% more beds than are available. And again, the uncertainty interval, repeating that definition for those who need the refresher. Here, this is figure 9 from that paper, and this is the cumulative number of deaths over time. So this graph is a little bit different. And based on the original forecast, by August 4th, they were estimated there would be approximately 81,000 deaths. And again, we have that uncertainty interval of approximately 38,000 to 162,000. So that just means right at the end of the graph that the low end here is 38,000, the high end is 162,000, and the best projection is 81,000. Now, again, I mentioned that this was a dynamic model. So they put together that original model. It was on March 26th, but they were using data through March 24th. But then they updated it, and they, on their website, put together a lot of detail regarding their April 2nd update. Again, it was 1 week after their initial projections. And what we're looking at here, this black line, which essentially ends at the very beginning of April, on April 1st, that's what's actually happening. That is what is reported. The blue line, so here is the blue line, and the dotted blue lines is that uncertainty interval. That is from the initial projections released on March 26th. So there it is the, this graph is the daily deaths, but the blue line, the area under the curve, represents a total of 81,000 deaths, just like we saw previously. Now the red line is the updated projections from a week later. You can see that the red line is a little bit higher. Again, the confidence intervals changed a little bit. But the area under the curve here, under this red curve, went up from 81,000 to 93,000 as they had more data available and were able to update the projections. So here we were focused on the deaths. Again, here are the deaths, which are represented on the graph. Likewise, the peak daily deaths, which are also represented on the graph. But some of the other changes you could see are in the peak daily hospitalizations, the peak daily ICU admissions, and the peak daily ventilator need. And you can see each of these went up. And again, that's not unexpected if the deaths are going up, and that's where everything is started from, and they're working backwards from there. It's not unexpected that everything else will go up. And then I put in the approximate shortages based on the April 2nd projections. And you could see that we are at the peak going to be on these projections about 88,000 hospital beds short and about 20,000 ICU beds short. I want to point out a few other things regarding this model, is that on April 4th, so yesterday, the actual number of COVID-19 deaths that were recorded, if I'm not mistaken, was 1,344. If you go onto the website, which I suggest you do, the URL is here, you could go and see that based on the April 2nd updated projections, the number estimated for yesterday was 1,360. So again, the estimated number for yesterday was 1,360. The actual number was 1,344. And another thing I want to point out just regarding what the next month is likely going to look like. A month ago, I just caught on the news, a month ago today, on March 5th, there were 11 deaths within the United States. As of within the last hour, and it is now 10:30 in the evening on April 5th, within the last hour, I saw that there are approaching 10,000 deaths in the United States. The actual number I saw was 9,633. If we move forward a month to May 5th, based on this model, the projected cumulative number of deaths will be 73,735. So 7 to 8-fold what it is right now. And some final thoughts. And I am going back to Harvey Feinberg, who again is that prominent researcher in the fields of health policy and medical decision making, who again was once the dean of the Harvard School of Public Health and the president of what's now the National Academy of Medicine. And he just a few days ago put this editorial in the New England Journal of Medicine, suggesting that if we take 6 steps to mobilize and organize the nation, we could defeat COVID-19 by early June. And these are the 6 steps that he laid out. A lot of these look familiar. They're things that have been in the media that are being talked about all the time. I think some of these are being done at different levels from state to state. And to some extent, I've started to see it happen at the national level also. I'm not sure, again, this is my opinion. I would like to see more, but I'm starting to see some hints of it, at least at the national level. And this was his closing paragraph, which I will read out loud. Rather than stumble through a series of starts and stops and half measures on both the health and the economic fronts, we should forge a strategy to defeat the coronavirus and open the way to economic revival. If we act immediately, we can make the anniversary of D-Day on June 6, 2020, the day America declares victory over coronavirus. There's something to think about. In summary, there is little evidence. In summary, there is little evidence of pandemic preparedness globally. We talked about the different types of epidemic curves that can be flattened, and we talked about the counts, rates, and excess demand. We had a quick little history lesson on the Spanish flu, providing a nice textbook example that non-pharmaceutical interventions can indeed work to flatten the curve. And we reviewed several models, one from the Harvard Global Health Institute, which is a static model from mid-March, and they predominantly focused on healthcare resource shortage. We then looked at a model from the Imperial College COVID-19 response team. Again, that is a static model that was put together or published in mid-March. That is where the 2.2 million death toll comes from without any interventions. That was cited by the White House during their March 31st press conference. And lastly, we got into the IHME or Chris Murray model. This is a dynamic, essentially a living model that is being updated. Here, we're predominantly focused on the death toll, but from estimated the death toll, they then move on to resource shortage. And again, that was cited by the White House on March 31st. A couple things in the works. Again, I'm a parent of 3 children. I get a lot of questions about the impact on pediatrics. I am trying to put that together, and I am getting a lot of questions regarding underlying conditions. I'm going to try to dig into that more. Some of the questions I've gotten are, for instance, if you have an underlying condition such as diabetes, but it is well controlled with medicine, are you still at more risk? Honestly, I don't know the answers. I'm going to try to dig into that and other similar questions to see if I could find answers. Lastly, please share this with friends, family, neighbors, etc. I'd like to think this is helpful for helping people better understand what is happening. And this is a weird phrase right now because I know nobody likes this, but let's just say if you think that the information I presented is useful, please like it on YouTube because that will help other people find it also. And one last administrative thing for those of you who I may have sent the link to, which is a small proportion of people who will hopefully see this, please just put your comments in YouTube as opposed to sending me emails, because if you have a question, it's a good question, and other people probably have the same question also. And it's a whole lot easier for me to see questions in the YouTube comments as opposed to if they're coming in with my email. So thank you very much for that. Anyhow, very important, maintain your social distancing. It is going to be very, very important for the next several weeks, and stay healthy. Thanks a lot. I appreciate your time.